You are listening to Medicine and the Machine with Medscape Editor-in-Chief Eric Topol and Master Storyteller and Clinician Abraham Verghese as they talk with experts around the globe about the hottest topics in healthcare. This podcast is intended for U.S. healthcare professionals only.
This is Eric Topol for Medscape, Medicine and the Machine, and with my co-host Abraham Verghese, we welcome Dr. Tom Insel, who led the National Institute of Mental Health for 13 years, from 2002 to 2015. He's also known as the nation's psychiatrist, and he has just written a book, published a book called Healing, Our Path from Mental Illness to Mental Health. So Tom, welcome.
Delighted to be here. Thanks for having me.
Well, we have so much to talk about. In Medicine and the Machine, we have not done justice to mental health and mental illness. And in your book, in all your work over decades, you've certainly taken this on. I'm going to let Abraham get things started.
Well, thank you so much, Eric. Tom, it's a great pleasure to meet you this way. And I've just got through your book, and I must confess that I was struck by how little I knew about mental health. And it's ironic because I work alongside the most distinguished colleagues, and we're always chatting. But I really learned so much from your book, and I was surprised by many things about it, especially I think by the notion that diagnosis, which is so fundamental to what we do in internal medicine, for example, is a very different beast in mental health. In fact, one of your chapters says diagnosis doesn't matter. Would you talk a little bit about that? Because I thought that was intriguing.
Well, it's been a difficult saga for the study of mental illness. It goes really back to World War II when the field began to realize that diagnosis was important, and we needed to come up with a way to distinguish the different forms of psychopathology, because we suddenly had a choice of treatments and we needed to know who would get which treatment. The attempt to do that was taken over by the American Psychiatric Association, eventually creating the Diagnostic and Statistical Manual, or DSM, which was a much needed innovation. It provided kind of consensus definitions of the major syndromes based on symptoms. But the problem has always been that it never went beyond those kinds of consensus descriptions. And there's value in that. It provided a common language. What I talk about in the book, and what I think has become a real problem for the field, is that what was really intended as a dictionary ultimately began to be used as an encyclopedia. People thought that somehow these labels were really truly valid, that they had scientific and biological validity to them. They were never intended to do that. They were never intended to even identify which person would get which treatment beyond a sort of vague bias towards one kind of treatment or another. So it's been a real problem for the field that we've never developed the kind of diagnostic rigor or the kind of validity to diagnosis that so much of medicine has enjoyed. And one of the results of that is that treatments are often kind of empirical. It's kind of hit or miss. We don't have the precision to say this individual will do best with this particular medication or this particular psychological intervention, or perhaps this neurotherapeutic effort, because that's available to us as well. Lots of good treatments. We just don't know how to match the diagnosis and the treatment yet.
Yeah, one of the statistics I got was how 1 in 20 Americans have serious mental illness, either schizophrenia, bipolar, or severe depression. But out of those, only some 15-16% have minimal therapy. So as you're saying, not only with precise therapy, but not even getting the therapy that are needed. Is that a fair summary?
Eric, I think it's a really important issue. I talk about it as the problem of engagement. Again, this is not such a problem in the rest of medicine. And I have to say, when I started the book, I was trying to carry forward a project that I've worked on for 40 years, which is to convince the public that psychiatry is just another discipline in medicine, and these illnesses are no different from endocrine or any other metabolic disease. And the more I worked on this, the more convinced I was that there's something fundamentally different here. And one of those is around this issue of engagement, that more than half the people who should or could be in treatment are not in treatment. Lots of reasons for that. Some of it has to do with the illnesses themselves. And one of the things that makes this particularly different is that the people who may need treatment the most are the ones who are least likely to seek it. Just the flip side of what you'd see in oncology or even in diabetes or cardiovascular care, where generally the people who are really disabled by their symptoms are the people who are going to be driven into treatment no matter what it takes to get there. When you find people who are truly psychotic and irrational, they don't think they're sick. And they'll do almost everything they can to keep from getting treated. And that makes this a really difficult problem to solve.
I think what's remarkable is that the treatment may not really depend on making an accurate diagnosis. In that chapter, Do We Need Diagnosis? You quote a psychologist, John Weiss, who talks about, the sort of commonalities of process that are helpful in almost all mental illness. And would you explain that a bit?
Right. So in terms of psychological therapies, where the field has gone after about 20 or 30 years of developing these kind of bespoke therapies, all of which have an acronym, CBT, DBT, IPT. There's a long list. Generally, there are 3 letters, and generally they end in T for therapy. But fundamentally, what people have been doing in the last 5 years or so is to say, are there some common features? I think there's a greater and greater recognition that good outcomes depend not just on the therapy, but the therapist. And so if you can find people who are good listeners and who are naturally empathic and who are able to build a rapport and a sense of trust, at the same time, give them some fundamental skills like John Weiss talks about, motivational interviewing skills, so they know how to help people talk about what's really bothering them. Skills of tools like behavioral activation that can help people who are shut in or who are particularly inactive to become more engaged and more involved. There's a limited number, actually, of those kinds of skills that seem to cross almost all therapies. And in the hands of a person who has the kind of empathic ability, seem to be quite effective. So you're right, it may not depend whether this person has a particular CPT code or they land on one page of the DSM or another, that some of these kinds of interventions are helpful across the diagnostic structure.
During your tenure, remarkable tenure at NIH, in those 13 years, you really fostered the basic research, the genomics, and all the things to understand mental illness. And one of the things that really is memorable for me is when Beth Stevens at Harvard discovered the complement factor underpinning of schizophrenia. And I was thinking, oh my gosh, this is amazing. This is going to transform schizophrenia, one of the most difficult conditions there is in all of medicine. And of course, that hasn't happened. Is that emblematic of the problem of making great discoveries of basic research, but it takes decades before they get actualized to improve outcomes? Or what do you think?
Well, there's a piece of that, Eric. I think, it's true across medicine. It's, as Francis Collins used to like to say, it's always a marathon. It's almost never a sprint. And getting those basic discoveries into new therapeutics it's a slog. I think that's especially true with something like that complement factor discovery, which is essentially discovering a risk factor for schizophrenia in germline DNA. That's probably a very long way from finding anything actionable for the disease. I think it's interesting, but whether it really will make a difference is kind of unclear to me. And we now have hundreds of those kinds of findings. And when you add them all together, you probably know as much as you do by taking a good family history. So I think it is important to understand something about the genetics of risk, but it's hard to see how you use that in any way that makes a difference. I guess in the book, as for me, it was so different from where I started, but I went from sort of thinking about those issues to then understanding that as important as it was to get a deeper view of the pathophysiology of these illnesses, somebody has got to pay attention to the fact that so many of the people with schizophrenia are incarcerated for having this disease, or they're homeless for having this disease, or they're dying at age 55 of pulmonary disease, chronic pulmonary disease, because they're smokers and they're been eating out of dumpsters, and they live a terrible life. And that's really what began to bother me. That's what the book became, was trying to understand, how can we allow that to happen for an illness that's fundamentally treatable, not curable, but treatable. And while the C4 discovery is interesting, I don't see how that reduces incarceration of hundreds of thousands of people. This is not a rare condition. We're talking about a situation in which today, in 2022, there are 10 times more people with serious mental illness incarcerated than in our public institutions for mental illness. I just find that egregious and unacceptable. And I have to say, I'm not sure I really understood that 5 or 10 years ago when I was at NIMH. I don't think I knew that was happening in the way that I now know it's happening, because I've spent time in jails and prisons, in homeless shelters. And I got this sense that I didn't have when I was so deeply involved in academic medicine and research on mental health, that this is as much a social justice problem as a scientific problem.
Yeah, you made that point. So you really underscored how it was supposed to de-institutionalize mental illness, and instead it trans-institutionalized to imprisonment. I mean, it's really extraordinary.
And that's on us. Really, it's on us. We just decided that we would put a tremendous amount of public funds into building jails and prisons. I think Brian Stevenson says one opened every 10 days through the 1990s. At the same time, we gutted our public mental health system, and there were no beds, and there were very few community centers. And so there was no capacity, and people who needed care didn't have any options except to end up in the criminal justice system. That's just not right.
Your choice of the word healing as a title for the book, I thought was really interesting, and I understood it better when I was done, in the sense that I think you're reflecting the feeling that I had after reading it, that there's so much broken with mental health. There's so much underdiagnosis, undertreatment, and also the importance of place and family. I love the passage where you quote Mandela's use of the word Ubuntu, which means in South African roughly means I am because of you. And would you expand a little bit more about that? It's not what I expected to read from a book by you, I must confess, and it was so refreshing to understand that.
Well, Abraham, it was actually part of this evolution that I went through. I've spent my whole career really focused on a kind of medical model, and this is one of the ways in which I think mental illness is quite exceptional. It's quite different. The medical model has worked so well for infectious diseases and for lots of areas of medicine. I think it's working very well for cancer right now, but it really hasn't worked for people with serious mental illness. It's led to a focus on symptom reduction, but not to a focus on recovery. And so the Ubuntu idea really comes out of this need to try to understand both the problems and the solutions in a much broader context. And that context I call recovery or healing. And I must say, I don't think I even fully understood what recovery was when I started the book. I was talking to a very wise psychiatrist who works on Skid Row in Los Angeles. And we were going on about recovery. He said, it's really easy if you want to understand this. It's just basically the 3 Ps. And of course, where I was coming from, I was thinking, well, there's Paxil, there's Prozac, and I couldn't think of what the 3rd P was. I thought, well, maybe psychotherapy. Technically, it's a P. And he stopped me and he just kind of put up his hand and he said, look, man, he said, it's people, its place, and its purpose. Those are the 3 Ps. If you want to help people recover, you have to help them find a life. They need people, place, and purpose. And in fact, we all need that, right?
Mhm.
But when it comes to people with serious mental illness, many of whom are incarcerated or homeless or just not thriving, we tend to forget this. We get very focused on their symptoms and whether we're getting the right level of medications, whether they have side effects. We don't think about their need for social support. Are they lonely? Are they cut off? Do they have someone who cares about them and someone who they care about? Incredibly important for recovery. Do they have a safe place to live, a sanctuary, a place where they can get decent food, where they don't have to worry about violence or being attacked? Um, and do they have a reason to recover? Do they have something to live for? As somebody said to me, I was at a clubhouse yesterday in Phoenix, and somebody said, what I need is for somebody not to ask me, what's the matter? I need somebody to ask me, what matters to me? And I
Right.
realized, in the medical model, we've missed all that. We don't do that. And yet for people to recover, this guy on Skid Row was right. I mean, those are the basics. Ubuntu is actually very much a part of that. It's part of that idea that we live in relationship to, and it's the connections we make and the sense that we have a relationship to others where they care about us, we care about them. There's a community there that is just fundamental. And the point I'm trying to make in the book is that's not rocket science. We can do that. A clubhouse does that, that we have everything we need to make that happen and to help these people who today are really our untouchables. They're kind of outside of our community. As President Kennedy said in 1963, he said, they remain alien to our affections. Well, we can fix that, and we can provide community, we can provide sanctuary, we can provide that sense of purpose so that they can thrive. We're just not doing it. And the book is a call to action to say, enough already. This must stop, and we must begin to care for people. And it's not going to be more genomics and more more neuroimaging. Absolutely, we need more of that. But the urgent need is to address what is this gross injustice, and we shouldn't put that off any longer. And we certainly shouldn't put it off until we know more about the pathophysiology of schizophrenia.
In 6 words in the last section on Way Forward, when you wrote Measure of the Soul of Our Nation, it seems like you really encapsulated this. Our nation is really hurting, and the pandemic didn't help that too much, nor is the war in Ukraine, watching these people getting massacred. What is the way forward, Tom? I mean, you're not only are so thoughtful about where we've gone off the track, but then you've also have worked and are working on technical aspects as well, of being able to understand the state of mind through keystrokes and all sorts of metrics. What is the best way forward from now, assuming there was an unlimited budget, which obviously there isn't, and other matters? If you could coordinate that, how could we fix this, and how could we regain our soul?
Again, I think most of what we need to do, we know how to do. So I don't think it's a mystery. A lot of it has to do with those 3 Ps and creating that sense of community. I have just been swept away by Ukraine, and I can't, it's been hard for me to talk about the book because I've been so focused on what's happening there. And I have to tell you, it's both infuriating and frightening, and also inspiring to see people come together in a way which our nation didn't do during COVID, but we're seeing it now in another nation, and maybe a nation that's being born for the first time, as people really do create this sense of common purpose and common sacrifice. So where I'm hoping the book will lead is to a new social movement that is really focused on those in greatest need, those who can't really support themselves and have become destitute, homeless, often incarcerated because they have a brain disorder, which, we would never let this happen to someone with cardiovascular disease or with asthma. I mean, it's hard to imagine that we've permitted this. And I think what we need really is to, first, that awareness that this is happening. I wrote the book with the idea that it would be a little bit like an inconvenient truth. It would be a wake-up call for so many of us who haven't, like me, haven't really been aware of how serious this problem has become. It's actually been made much worse by COVID. You're absolutely right about that. And so now these issues are becoming more widespread. We're seeing enormous mental health issues for young people coming out of COVID. And as you both know, in California, at least in the Bay Area where I live, we lost far more young people to overdoses and suicide than we did to COVID. So this is a far more fatal problem. These deaths of despair, as we call them, have really become now a more urgent issue. Over 100,000 overdose deaths last year. So what do we do? What's the solution? I think a part of it is this increased awareness, the beginning to name it and beginning to understand that just as we did with COVID, we've got to call this out. The Surgeon General has done that recently with youth suicide. I'm delighted to see the administration come up with a fact sheet that lays out a whole game plan for how they want to address the mental health crisis and call it a crisis. That's pretty extraordinary. I think it's the first time in 41 years that the White House has even used the term mental illness or mental health. Pretty extraordinary to see that. So leadership matters. Leadership will be helpful. But fundamentally, this is a bottom-up effort. It is creating community and creating community resources. Clubhouses are one way to do that. I think community clinics, the idea of using schools as a kind of a center for providing resilience and teaching kids about both social and emotional learning, what they need to know to be able to compete in a brain economy, giving them what we call brain capital, by giving them a set of skills that allows them to talk about mental health issues and be able to develop resilience around that. We can do all this, and it's on the agenda for the White House. Actually, it's a huge issue here in California, where we have a governor who has committed $4.4 billion for youth mental health. So our governor's idea is that you're never going to cure your way out of this. You're never going to have enough clinics. You have to move upstream and begin to talk about prevention and sort of population approaches to helping people deal with so many of these issues. And so I think there is a game plan. I think there's a lot we can do. I try to capture much of that in the book. But I have to say, when I finished the book, which was a year and a half ago, I didn't realize that we would be moving so quickly from top down, that there'd be so much going on in Congress, so much in the White House, that the leadership in places like California would just take this topic and really run with it. So there's a lot happening, more than I've seen in my 4 decades in the field.
Wow. Well, that's very reassuring.
I think it's a great time to be taking on these issues. That was actually the president's comment. He said, let's take on mental health in his State of the Union message. And I think there's a momentum to do that. But I just want to caution that it's not just about money and policy and programs. There really is a need for building up this community that I think we had more of when I was a kid, when I was growing up, and when I first had my kids 40 years ago. We had more of a supportive community than we have today. It's harder for parents, it's harder for kids. We can get back to that, we can fix that, but it's got to be both bottom up and top down.
The statistics you had in your book about prisons was really a revelation to me. And I was struck by one anecdote of the prisoner who was anxious about being released because, paradoxically, he had community in prison, and once he left, and he had medication and he had purpose and process, and once he got released, he would be, just back out there swimming in the in the world without any assistance. And it made me wonder if there wasn't more opportunity, given the numbers that are, incarcerated, not that it's ideal, but if there wasn't more opportunity to deliver the kind of place, people, and process that is needed.
Yeah, I think it's a great question. And there are places doing that, trying to provide better care in the criminal justice system. But it's a Band-Aid. It's simply not. The criminal justice system is essentially set up for punishment, not for therapy, not for even rehabilitation. I think we have to hit reset on this and begin the process of rebuilding the infrastructure, the network of services that are in the healthcare system. That also requires us actually reframing what we mean by healthcare. That I think we have to, and that's part of what I was trying to do in the book, is to get us to talk about health as being something more than what we today call healthcare. It does require this recovery focus, these 3 Ps. Just to make it more concrete, why not have caretakers be able to write a prescription for housing or a prescription for food, or even be able to have Medicaid or private insurance pay for a clubhouse? None of that happens today, but those are not impossible to imagine. So what I'm inviting here is that we rethink what we mean by healthcare in the context of mental health anyway, and that we decide that while the criminal justice system is kind of where that's been happening, we can't ever expect the criminal justice system to become an ideal place for someone to recover. They're not criminals. These are people with an illness, and we ought to accept that. There's a quote in the book which I found. I'm not even quite remember where I found it, but it was from Abraham Lincoln, in which he said something like he wanted to remind somebody that melancholia, which was the old name for depression, is a misfortune, not a fault. And we've forgotten that. I think we've really treated this as if it's a fault or a crime, and criminalized the very thing that we should be treating. I just think that's something we've got to start to turn around. There's an attempt to do that with a reformed crisis service that's called 988, that Congress is requiring every county in America to put in place by July 16th of this year. 988 will mean that if you're in a mental health crisis, you don't call 911 and get cops with guns or an ambulance set up for a medical surgical emergency. You get a nurse, or you may get a social worker, perhaps a nurse, maybe a peer. They come in a van and they can spend, if needed, hours with you to kind of help you through that crisis. If you do need to be hospitalized, you don't actually have to go to a medical surgical emergency room or to a jail. You end up going to a psych emergency room. We call these crisis stabilization units. And then there's a whole system that goes from there. So what we have to do is just build out that pathway, which is happening around the country, but not fast enough. And it's not, and often what we're seeing is counties are building out one part of it, like the 988 phone line, but they're not building out the mobile crisis vans. They don't have the workforce. They haven't thought about where people get dropped off. It's a lot to fix here, but we know how to do it, and we know what needs to be done. And now it's a matter of making the commitment to make it happen.
It's great that there's a movement that's getting rooted. It seems like it's a bit chasing the tail, where you have the opioid epidemic, as you've already alluded to. You have homelessness, perhaps at record numbers throughout the country, certainly here in California. And it's about time that we get this thing on track. I do want to just touch on the lesser form of mental illness, which is the more common. Most of what we've been talking about throughout this conversation is, the really serious stuff. But what the pandemic brought out is a lesser form of, depression and anxiety that's pervasive. naturally because it's reactive. And there's not enough people out there to help these folks. I want to know what your sense is about the apps that are out there, that are marketed for X number of dollars a month, and, the CBT and all these other ways to support people at this very difficult time that they're experiencing. And, it doesn't seem like the pandemic is really over and people are still, suffering, not in a severe way, but, in this needing help.
Right. Well, I'm glad you brought that up because probably most of the people listening to this broadcast are thinking about anxiety in their kid or depression in their family, which isn't at the level of requiring incarceration or anything else. We have gone through this transformation accelerated by COVID from the kind of brick and mortar world of therapy with your 50-minute hour once a week to a world in which people can access psychotherapy and now even medication online with a click much more easily. It's a little bit like what we saw with Amazon and Uber. It's really a transformation that provides convenience and access and timeliness, and all of that has been, I think, extraordinarily helpful for a lot of people. The yes, but part of this, the caveat, is that for the most part, what we see is what people were doing in the brick and mortar setting is about what they're doing on Zoom or through some app. What we haven't seen is a change in the quality of care and the quality of services. And a lot of what concerns me is that we have treatments, we have psychological treatments that work quite well, that require learning a set of skills. And yet that's not what much of the workforce is trained to do. It's not what they deliver. And again, we would not accept this in the treatment of diabetes or hypertension. People are pretty much required to do what the science tells you works. But in the world of psychotherapy, it's been much more free form, and people give what they're comfortable giving. You get what you get really depends on who you access. And so I think this shift to teletherapy is really interesting and really potentially transformative. But this I say the first act of the 5-act play, we're in that first act, has just been about access. It's not that interesting to me in terms of overall changing outcomes. That'll come in the second act as we really start to focus on quality. And we begin to use the tools we understand, as you were saying, Eric, tools that measure outcomes and measure change and even measure therapeutic alliance and trust, those kinds of really important issues in psychotherapy. And we can begin to capture those in real time. And I think by giving feedback, not just to the patient, but to the clinician, to the provider, we can improve care. And as you improve care, you will improve outcomes. I have no doubt about that. But that's Act 2. We haven't gotten there yet. And that's still the work to be done, I think, in the next, I'd say, 3 to 4 years.
Coming back to diagnosis for just a moment and recognizing that it's not as vital as it is, say, in my specialty of infectious diseases, you recognize that genomics did not hold the potential that we once thought it might have for mental illness. Does functional MRI, is that going to be the way we classify things? And if not that, what is the next best thing? I'd like to think as a scientist that at some point we will find the substrate that allows us to parse these things out, or is that a naive idea altogether? Have you dismissed that from your thought process?
I have not, Abraham. I actually, and I would push back a little bit that diagnosis doesn't count. I think it does. And even today, the categories we have, they're not perfect, but they're a start. I just think, as you're suggesting, and as we would do in infectious disease or in oncology, we have to get past symptoms. We have to begin to think about other measures. fMRI, very difficult to scale and difficult to do. There's a paper out in Nature this week on the use of MRI, not fMRI, but MRI itself, showing that the effect, there's so much variation in the human brain, in the connectivity and in the structure, that you need literally thousands of patients to be able to get reproducible results when you're looking at depression versus healthy. So while there are literally thousands of papers that are out there, most of them are not reproducible because of the inherent variation and the fact that the effects we're looking at are rather small. Same problem we had with candidate genes and genomics when we started that 20 years ago. I do think, though, there are other ways to get at this. fMRI may be useful academically to demonstrate the circuitry differences or the biology for, let's say, the 3 or 4 different forms of depression or the 2 or 3 different forms of OCD. I think there will really be some value, but I don't think it will scale as well as EEG. So I think using something like EEG ultimately could become like EKG is in cardiology, where it's in every primary care doc's office. And I could imagine because what's happened in the last 3 or 4 years is the advent of machine learning and AI approaches to EEG have transformed the way we use those signals. And they have, in fact, given us much, much better precision around the diagnosis of PTSD and depression. But to be clear, there's no magic bullet here. It's probably not going to be just EEG with good AI. It's going to be EEG along with cognitive testing, along with data from a wearable that tells you about sleep and activity and maybe even social interaction. And then symptoms need to be in there as well, and subjective experience. And I think what we've seen is if you put those together, you can in fact begin to define subtypes of the major mental disorders that are predictive of treatment response. They are beginning to get us to precision medicine, but unlike in oncology, it's not a single genomic defect. It's going to be multiplexed. It's going to have to be 3 or 4 things we put together. And they have to be something that will be easy enough to do in a primary care doc's office, because 80% of depression, a little more than that, and anxiety is treated in primary care. It's not in specialty care.
Well, this has been a terrific conversation, Tom, and we're indebted to you for many reasons, not just for having this conversation. What you've done in your career has been momentous, not just, of course, your leadership at the NIH, but the book you put together, really, which was not a book that would be expected from Dr. Insel at all. It was, as you say, perhaps the work that you put into it led to this epiphany and a kind of reinvention type thing, but it's remarkable. I hope that the people that get to listen to this really learn about the 3 Ps and a lot of wisdom that you've imparted to us, and the hope that we get this finally in a better place than it's been for many decades. In fact, it obviously has gotten worse over time rather than better. This is a chance to have an inversion of that. And I wish you were running the whole program to do that, but maybe your ability to advise the key people of our government leadership and others will get us there in some way or other. So thanks so much for joining us.
Well, thanks for having me. And I am hopeful. I hope that, if nothing else, that the book transmits that, because I think we do need hope at this moment to figure out how to fix so many of these things, and we can do it. It's a commitment. It's nothing more than just making a commitment. Thanks to both of you. Enjoy the conversation.
Thank you.